Good evening, everyone. Good evening, and welcome to you all. It's great to see so many people here. This is wonderful. My name's Professor Dylan Edwards. I'm the Pro-Vice-Chancellor for the Faculty of Medicine and Health Sciences, and it's a huge pleasure to introduce Professor Tina Jerosch-Herold to give her inaugural lecture tonight. You don't mind if I call you Tina instead of Christina? That's good. So Tina qualified as an occupational therapist in Oxford originally, and then began her clinical career at Addenbrooke's Hospital in Cambridge. And there she specialized in the rehabilitation of hand injuries and developed an interest in nerve injuries and clinical assessments. A UK Department of Health AHP scholarship enabled her to study for a master's in rehabilitation sciences at Southampton University, before joining the then School of Occupational Therapy and Physiotherapy here at UEA in 1992. Following completion of a part-time PhD, actually in my old school in bio, apparently, in 2002, Tina developed a growing program of externally funded research to evaluate interventions for disorders of the hand. In 2009 and in 2013, Tina was awarded successive prestigious NIHR research fellowships, a career development fellowship, followed by a senior research fellowship, to investigate methods of improving the clinical management of carpal tunnel syndrome and outcomes of intervention. So during her time at UEA, she's been a busy person. She's held numerous roles. She's been course director for the BSc in occupational therapy, led the development of a new speech and language therapy degree, and was associate dean for postgraduate research in the faculty. Tina's research has resulted in over 60 peer-reviewed papers and 9 book chapters in instructional textbooks for trainee hand surgeons and hand therapists. She's a guest lecturer on the Masters in Hand Rehabilitation in Lund University in Sweden, and has delivered bespoke training courses and masterclasses in the UK and Europe for clinical hand therapists. Her contribution to the field of hand therapy, especially relating to evidence-based assessment and treatment of peripheral nerve injuries and outcome measures, was recognised by the British Association of Hand Therapists in 2010 with a Natalie Barr Award. Tina's the editor-in-chief of the Journal of Hand Therapy and a member of the editorial board of the Journal of Hand Surgery. Her current research is looking at whether we can predict how patients respond to different treatments for carpal tunnel syndrome, with the long-term aim to develop a stratified, personalized care pathway. So tonight, Tina's going to show how research and innovation have contributed to the assessment and treatment of hand problems caused by injury and disease, and set out the challenges we still face when restoring function to this truly sensational part of the human body. Please join me now in welcoming Professor Tina Jerosch-Herold to give her inaugural lecture.
Thank you very much, Dylan. Can you hear me at the back? Yeah? Okay. So a very good evening to all of you, and thank you very much for coming, especially some people who've come a very long way, and also to all those who are joining via the live stream. Let me begin by getting you to consider your own hands. Are they mere appendages at the end of your arms that perhaps you take for granted, that we even abuse? Or are your hands so precious to you and valuable to your daily lives that perhaps you have to insure them? What was the first thing that you did when you woke up this morning? I hazard a guess that it was using your hands. Maybe you lunged for the snooze button. You will have held your hand out to check that the shower is hot enough, warm enough. You will have switched on the kettle, boiled that first cup of tea, and hold it in your hands. And really, as we cast our minds back to just an ordinary day, it's not ordinary for me, but an ordinary day, then we can't but wonder how we would manage really without our hands. So in tonight's lecture, I really want to explore what makes our hands so special, why and how injury and disease can have such a profound effect on an individual, the highly specialist skills of surgery and rehabilitation required to restore function, and also what challenges remain. I will be drawing from some of my own research, but also research from others in the field. Now, it seems that every inaugural lecture has to include at least one embarrassing picture of the person giving it, preferably in their former years. And there are many I could have chosen from, but actually this one stood out for me because it captures for me what using my hands and how much pleasure means and how much pleasure using my hands gives me. So from a very early age, I enjoyed making things. Here I was making sand patties on a beach in Portugal, where I grew up. And I did progress. However, it's fair to say that I did not excel in school. I didn't particularly enjoy school, but I was quite good at making things, often gifting them to people. And I suppose it was that creative side that certainly led me to choose occupational therapy as a career and which took me to Oxford. It was whilst working at Addenbrooke's, which was my first post in Cambridge as an occupational therapist, that I had the opportunities to specialise in hand therapy, and which set me on a path which really retrospectively this evening might look very linear and very coherent to you all, but of course the lived reality is never anything like that. Now, during my time there are two particular individuals who I'm very deeply indebted to. One is Carol Fraser, the person here second from the right, and she was the head of the department who nurtured my growing interest in research, which was really very unusual. This was at a time that occupational therapists did not have degrees, let alone higher degrees. Now, the very eagle-eyed amongst you might notice that A, I've got streamers around my neck, which was not part of the usual OT uniform, I assure you. But between Carol and my younger self, Prince Andrew seems to be making an appearance. And it was one of the only photo I have with Carol on it, which is why I chose it. But I realized I could date it perfectly because it was taken on the day that he wed Sarah Ferguson. And it being a weekday, we had to work, but it was an excuse to have a party. So Carol brought in a cardboard cutout of Prince Andrew, dressed him in an OT uniform, and we carried on seeing patients, but we had a bit of a lark on that day. Now, the other very important person was Murray Mathewson, who was a New Zealand hand surgeon and who was a great mentor and teacher. Sadly, he passed away only a few months ago. And he really taught me what true teamwork was like, and it was about absolute mutual respect for each other. For me, respecting him as a surgeon, but equally him really respecting my hand therapy skills. Now, for those of you perhaps who are unfamiliar with the field of hand therapy, it is a specialization for occupational therapists and physiotherapists. We work very closely with hand surgeons, a surgical subspecialty of orthopedics or from plastic and reconstructive surgery. And of course I would say this as a hand therapist, but the post-surgical aftercare provided by a specialist hand therapist is absolutely critical to what the surgeon has done in the operating room. Now, I know that there are at least 2 hand surgeons in the audience who would not dare to argue with that because their wives are hand therapists. Now, some would describe that this relationship is symbiotic. Hand surgery and hand therapy emerged in the UK in the 1940s when specialist rehabilitation units were first established to treat wounded servicemen, and RAF Chessington and Headley Court, where Kit Wynne Parry, gentleman on the top, who was a physician, together with Natalie Barr, an occupational therapist, and Maureen Salter, a physiotherapist, pioneered multidisciplinary hand rehabilitation. And then the first civilian hand rehabilitation unit was started in 1952 in Grimsby, headed by Guy Pulvertaft, another giant of hand surgery, who was also the first president of the British Society of Surgery of the Hand. Today, we have our own societies, each promoting education and research through conferences, instructional courses, bursary and grant schemes, and also our own society journals. And this close teamwork is not just evident between therapists and surgeons in the hand clinic setting, but also globally in the joint European and international congresses that we hold together. So you may ask yourself, what makes the hand so special that it sets itself apart and has a named subspecialty? So the hand and wrist is made up of 27 bones. We have 2 hands, that makes up 54 bones. The whole human body has 206. So about a quarter of all our bones are actually in these tiny little appendages. We also have 15 extrinsic muscles that mostly in the hand have actually turned into tendons and that work as powerful pulleys. We have 11 intrinsic muscles acting upon the wrist, the palm, the fingers, and the thumb, and also 3 nerves. And together, they really give the hand a unique blend of strength, of stability, and absolutely unrivaled dexterity. The human hand actually has 27 degrees of freedom. And this is a fact which the robotics and the animation industry still grapples with, because when you look at models of the hand, actually particularly in animation in computer games, they're actually very simplified versions of what it's really capable of. Human hands have evolved as we have evolved. We used all 4 limbs to move around, to become bipeds, and with it, our intelligence has evolved. Hands have fascinated artists, philosophers, theologians, and scientists. The Earl of Bridgewater commissioned a Scottish surgeon and anatomist, Sir Charles Bell, to write the 9th Bridgewater Treatise on the hand, its mechanisms and vital endowments as evincing design. It was published in 1837. It's a work of natural theology, but one in which Bell emphasizes that the hand is as important as the eye in the field of surgery, and that it must be trained. And I was reminded of that only this morning when I heard on the BBC that some professor is appalled at the lack of dexterity skills that young doctors have in putting a suture in. The human hand is also viewed as an extension of the brain. Descartes called the hand the outer brain. So the hand is truly sensational. But I also chose this adjective very deliberately because it is sensation and the sense of touch that has really fascinated me. Not only does touch help us protect from harm, it's critical to the development of infants. In fact, if you deprive a child of touch, it will become developmentally delayed, as we saw in the harrowing pictures of children in Romanian orphanages. Touch is intricately linked to our emotions. Another reason why skin-to-skin contact in newborns is considered so important. And in fact, recently researchers have discovered that we have a very specific subset of sensory afferents called C-tactiles, which interpret the touch just related to social bonding. Sensory feedback is also critical to skilled movement. Through touch, we can regulate the force of what we hold, tight enough not to drop the glass of water, lightly enough not to crush the bird. And this is made possible through thousands of receptors that innervate our hand, with the highest density of these in our fingertips. We have special pain and temperature receptors, which give us what we call protective sensation. And we also have 4 different types of what are called mechanoreceptors, which basically respond to different forms of mechanical deformation of the skin, each tuned to convey a different bit of information about the tactile world to the brain. So constant moving touch, vibratory stimuli, and even skin stretch. Most of these are located within the papillary ridges. So the whorls on the tip of your finger, which give you your unique fingerprint, and one that is pretty essential these days if you want to operate your smartphone. So these papillary ridges contain thousands of receptors capable of differentiating smooth and rough surfaces, but also the distance between edges. And this varies greatly across the body's surface, and even within the hand. And it can be measured by asking people to tell you whether they can distinguish two closely spaced points. And in the fingertip, people can normally distinguish two closely spaced points at a distance as small as 1 millimeter. This tactile acuity does change over lifespan, and we do lose touch receptors, and with it our tactile acuity declines, as does our vision and our hearing. The only exception is we don't have hearing aids or prescription glasses for our declining tactile acuity. We just simply adjust to it. But it's not just age which differentiates different levels of tactile acuity, but even in two adults of the same age, we can observe differences. And these appear to be related to sex. So this is the ability to distinguish very narrowly spaced gratings orientated either vertically or horizontally. And as you can see in the diagram there, women seem to do better. They're able to detect at a lower threshold. But a research group in America, Goldreich, actually did an ingenious experiment in which they were able to quantify the number of receptors and without taking painful skin biopsies. And what they actually found was that where the fingertips are smaller, we simply have the same receptors, but they're crammed onto a tighter space. So small is beautiful. Those of you who've got small hands will have better tactile acuity. Now, all this is also possible because we have a part of the brain which processes this information from these receptors, the somatosensory cortex. And it's organized like a map, but this map is greatly distorted. So the areas which have lots of receptors that are very richly innervated also are overrepresented. As you can see, particularly in the 3D figure this figure is normally called the sensory homunculus. So the hands, the lips, and the face are grotesquely large because you need more proportion of the brain to process all that information. This map is also not static. It changes according to the demands that we make upon it, a phenomenon that we know as cortical plasticity. So, for example, if somebody loses a limb, then the representational area of that hand in the brain will actually disappear and shrink. And what I couldn't get in the animation, but actually happens in reality, is the adjacent areas just simply creep in. And similarly, increased use, so for example in professional violinists, will also result in a higher tactile input and therefore an increase in size of that representational area. And interestingly, in blind people who rely a lot on touch, it's been shown that the braille reading index finger, the representational area for that digit, is much larger than on the contralateral hand. So I'll be coming back to this phenomenon in some of my later slides. Touch is also a sense that can compensate for other senses. Some of these famous examples are Evelyn Glennie, who is a profoundly deaf percussionist who relies on the vibratory touch, and Helen Keller, who became blind and deaf in childhood and used touch to finger read, to lip read, and obviously to read Braille. But all these examples highlight what the hand itself is capable of when it's free of injury and disease. I promise you won't see anything more gory than this. I decided to be very restrained. So, going back to my work as a clinical hand therapist, I came across patients who lacerated major nerves in the forearm. Sadly, something that happens very easily, people fall on glasses, fall through glass doors. Now, these would be surgically repaired, although I would argue that the term repair is a little bit of a misnomer, because actually all a surgeon can do is suture together the outer connective tissue that holds the bundles of axons together, because you can't actually suture nerve fibers, and the distal portion to that will die and will have to regenerate. And of course, the more proximal that is in a limb, the longer it takes for that to regrow. It regrows at around a rate of about 1 millimeter per day. So peripheral nerve trauma, even in the forearm, even at the wrist level, quite distal, is a life-changing injury for many. It involves a very lengthy rehabilitation, and recovery is very slow. The wounds heal often with invisible scars, and of course the hand sort of looks normal. But yet this severe sensory loss takes years to improve, and often the fine discriminative sensibility never returns to normal. Now, you might be wondering what these little cute lambs have to do with my talk. Well, earlier this year, I had the pleasure of reading this, I think it became a bestseller, The Shepherd's Life by James Rebanks. And in there is one particular passage where he talks about his work in the lambing shed. And it just brought me back to a patient that I treated. And she too was a sheep farmer. She had injured her median nerve and ulnar nerve, so had pretty much all of the sensory supply to her hand cut off. And she decided to return to work at 8 months and did have some returning sensibility, but it was very imperfect. And I don't wish to be too graphic this evening about what happens in the lambing shed, but when her hand was out of sight, she came to that nasty realization that she had got hold of something and she didn't know if it was the lamb's leg or the lamb's head, with potentially disastrous consequences. And she had to change her job, which she loved. Erik Moberg, who is the father of hand surgery in Sweden, said that the hand without sensation is blind. That picture of the eyes in the fingertips, that's Moberg's. He also pioneered methods for assessing the functional value of sensory recovery after nerve injury. Given the very slow recovery in patients with sensory impairment that I often saw, you often see them over many years. And what they want to know is whether they're actually making progress. Of course, they can gauge that themselves too. But it's why I became interested in finding ways, objective ways, by which I could quantify that they were at least improving or working moving in the right direction. And so I wanted to do this properly, and I soon realized that if I were going to do this properly, I really needed some research skills under my belt, which I sorely lacked. And developing better methods for assessing sensory function of the hand was really my motivation behind studying first for a master's and then later a PhD here at UEA. So these were some of the questions really that were the guiding questions to my master's and PhD work, and led to some publications. Now, when I came to UEA in 1992, and I started my PhD, I think in 96, if I remember correctly, the school was still quite small, and actually, due to the lack of suitable supervisors, or even supervisors in my own field, I ended up in the School of Biological Sciences, and where David Adeley and Professor George Duncan took me under their wing. Now, there seemed to be a plethora of clinical tests already available, but many lacked rigorous research to support their use. So as well as reviewing the evidence for their validity and reliability and responsiveness, I proposed a simple conceptual hierarchy for selecting these tests and for recommending a core set of tests that can be used to assess nerve injuries. I also began to challenge the widespread use of two-point discrimination and developed an alternative method for testing localization, another form of spatial discrimination, called the locognosia test. Now, whilst doing my PhD, I was fortunate to come across another OT, who was also a hand therapist from Sweden, who was doing a PhD in a very similar subject, which always worries you when you're doing a PhD. And then I thought there was an opportunity to meet her at a conference, and I thought, well, there's only one way to find out. She either is doing what you're doing for PhD, in which case that's curtains, or she's not. So I met her for dinner. And really, the rest is history, as they say, because out of it came a great collaboration and a great friendship. And Birgitte Rosen did some fantastic work and developed, amongst other things, a composite impairment score for nerve repair called the Rosen score, and which includes many of these sensory tests that I had also researched and reviewed. Today, some of our published work on sensibility assessment forms part of the clinical assessment recommendations that the Swedish National Registry for Hand Surgery have adopted, and also the American Society of Hand Therapists, their clinical assessment recommendations. And it's also led to some book chapters on sensibility assessment. Now, up to this point, I had focused largely on objective measures of hand sensibility. But increasingly, I came back to the question which Moberg asked back in the 50s. What is the functional value of the returning sensation to the patient, and what can they actually do? It also became evident from my own work and that of others that clinician-assessed outcomes are sometimes at odds with what the patient reports they can or cannot do. And the latter is really what can be assessed using patient-reported outcome measures, or PROMs as they're abbreviated. They capture the impact of a health condition from the patient's unique perspective, and they're actually increasingly being advocated for use as endpoints in clinical trials and are integral to value-based healthcare. So I decided that it was time to develop a new PROM for nerve disorders because the existing ones were not suitable. And thanks to a faculty-funded PhD studentship, we were able to recruit a hand therapist, Mark Ashwood, who developed a new PROM for hand nerve disorders. And Mark is one of several PhD students that I've had the great privilege to work with and supervise. So he undertook a mixed methods study using current standards for PROM development. And there were various phases to this, using existing literature and accounts of patients' lived experience of nerve injuries and nerve compression. He generated the content for the new measure, and then following cognitive interviews with patients and further refinements to the scale, he then evaluated the psychometric properties of the new scale. And we called this the Impact of Hand Nerve Disorders, or IHAND scale. So now we have a patient-reported outcome measure for patients with nerve trauma and nerve compression, which they find highly relevant and easy to complete, which clinicians are adopting into clinical practice, as well as being proposed for primary endpoints in clinical trials. And it complements the impairment score, which Birgitte Rosen developed, and together they will really facilitate the comparison of outcomes from nerve surgery and rehabilitation across centres and across countries. Now, nerves can be damaged through gradual compression also, and carpal tunnel syndrome is the commonest nerve compression disorder in the upper limb. So I turned my attention to this, not only because it's very common, but actually the incidence of nerve trauma over the 20 years that I researched it is also declining dramatically, and that's a good thing. It's partly because of all the tighter health and safety laws. But as a researcher, that makes it very difficult because it takes you years to recruit patients. Whereas carpal tunnel syndrome, sadly, is on the increase. It's where the median nerve becomes compressed in the wrist, causing tingling, pain, numbness, and muscle weakness, as well as some nighttime waking from these symptoms. The symptoms can be mild, even transient, as they are sometimes in pregnancy, but they can also become chronic and severe, and often they affect both hands. It's more common in women than men, and it's estimated about 1 in 10 people at some point in their lifetime may experience these symptoms. Treatment for carpal tunnel syndrome includes splints, steroid injections into the carpal canal, and surgical decompression, where basically the ligament, the flexor retinaculum, is cut to vent and give the nerve space. But surgical decompression in England, in the NHS, is currently restricted to people with severe symptoms or those where conservative measures have actually failed. If you're not come across anybody with carpal tunnel syndrome or not experienced it yourself, it may give you some idea of what it's like to live with it from a study we conducted about 10 years ago, where we wanted to understand the experiences of people with carpal tunnel syndrome, but also what they expected from surgery. And I think these quotes really speak for themselves. Around this same time, I was fortunate enough to be awarded another fellowship, my first fellowship by the National Institute for Health Research. So building on the work that I'd done on sensibility assessments in nerve trauma, I now wanted to know whether these tests which tests of sensibility and strength were better at detecting change in people who were undergoing surgery for carpal tunnel syndrome. Now, what surprised me was that these were patients who'd undergone surgery, and at 8 months after surgery or longer, they still had quite substantial sensory impairments. So about 65% of patients had abnormal detection thresholds, 35% couldn't localize correctly, and 30% weren't able to recognize shape and texture at a level that you would expect. And this really led me to another research question, which is, can a treatment called sensory relearning improve the sensory function in people with carpal tunnel syndrome? This brings me back to cortical plasticity, because that's what sensory relearning uses. It was first developed by Wyn Parry and Lee Dellen in the US, but more recently extended through the work of Professor Johan Lundborg and Birgitta Rosen in Sweden. And there is moderate evidence that it is effective in enhancing sensory recovery after peripheral nerve trauma. But there was no research that had looked at whether we can use this in people who've got residual sensory impairments after carpal tunnel syndrome. Now, sensory relearning is a gradual and progressive process of reprogramming the brain through the use of cognitive learning techniques such as visualization, verbalization, the use of alternate senses such as vision or hearing, and the use of graded tactile stimuli designed to maintain or restore sensory areas affected by nerve injury or compression, and designed really to improve tactile sensation and something that we call tactile gnosis, the ability to recognize shape, form with your hands. So we designed a small-scale trial to test the methods and the acceptability of this intervention to patients, and to see if it was worthwhile to proceed to a definitive trial. So patients who had sensory deficits at 1 year or more after surgery were randomized to either receiving sensory relearning for 4 weeks or no treatment at all. And we did observe a trend favoring sensory relearning. Remember, this is a small-scale trial, not powered to detect significant differences, but it did also suggest it was acceptable for patients, and we went on to conduct a larger definitive trial. As in the pilot trial, we used standardized materials and instructions because it was an unsupervised sensory relearning home program that we gave patients to do. And we also extended the intervention period from 4 weeks to 6 weeks in the trial, and also we had a longer follow-up period of 6 and 12 weeks. Now, despite a longer intervention and follow-up period and a much larger sample size, therefore the study was adequately powered, the efficacy analysis did not show any statistically significant differences between the groups. So all of these p-values in the last column, they're non-significant for the objective sensory tests. There was a small significant improvement in hand function favouring the sensory relearning group on 2 of the subtests for patient-reported hand function. We also did a secondary analysis that suggested that there was a dose-dependent relationship. So when we took into account how much people had actually done the exercise, how adherent they were, we also found that higher adherence meant that they derived greater benefit. But really, the results did not justify the use of sensory learning in this group of patients. But perhaps what we should be looking at is at preventing these severe chronic sensory deficits in the first place, perhaps even by intervening earlier. So this is why I also decided to then turn my attention to a much broader question of how carpal tunnel syndrome is managed from the outset after diagnosis. And in 2013, we started a large multi-center prospective cohort study of patients diagnosed with carpal tunnel syndrome, which we called the PALM study. We wanted to study people newly diagnosed with carpal tunnel syndrome, follow the clinical course of the disease, how it impacts on the person, and to try to identify factors that may predict how they will respond to the 2 main treatment approaches, so steroid injection and surgical decompression. Now, carpal tunnel syndrome accounts for approximately 55,000 operations per annum on the NHS, costing around 42 million. So it's not an insubstantial amount of money or numbers. And so we also wanted to identify predictors of cost, not just cost of surgery or steroid, but actually other costs to the individual and society, so taking a broader societal perspective as well. Now, for these kinds of observational studies, you have to recruit hundreds of patients, and we wanted to follow them up for up to 2 years or at least 18 months before we have enough data that we can actually model the outcome. Now, patients completed online or postal questionnaires at baseline, and we had 754 patients do that, and then they were repeated every 6 months. Now, the models of predictors of outcome and predictors of cost aren't yet published, so I'm not able to share these results with you this evening. But we were able to look at the baseline data of these 754 patients enrolled. And we decided to explore the associations of carpal tunnel symptom severity with hand function, psychological status, and health-related quality of life. Now, we assessed carpal tunnel syndrome severity using 2 methods. One is objective disease severity, which is graded based on nerve conduction tests, and the other was through a patient-reported symptom questionnaire called the shortened Boston questionnaire. Now, we found that patient-reported symptom severity, which we've classed here as from none, mild, moderate, severe to very severe on the bottom, that it was highly significant independent predictor for hand function. So as the severity increases from left to right, so you can see that the hand function score decreases. A lower score is poorer hand function, and in fact very markedly. Now, we also found that hand function was significantly associated with the objective disease severity, so nerve conduction tests, but less so. Now, when we looked at psychological health, we saw a similar trend. Higher scores on the vertical axis indicate higher anxiety and depression scores, And the mean scores for those with severe carpal tunnel syndrome, on the right here of the diagram, start becoming borderline or even cases of anxiety and depression. Finally, when we looked at quality of life, which here has been converted into something called a health utility that can be scored from 0 to 1. So 1 means perfect health, 0 is equivalent to death. So a higher health utility is better, higher quality of life. And again, we can see a very marked decline, especially in those with severe and very severe symptoms. So the very severe symptom group has a health utility of 0.43, and that's a health utility similarly reported in people with psychotic illness, digestive cancers, and severe heart failure. We didn't find that objectively graded severity from nerve conduction studies were associated with either psychological health or with quality of life. When we modelled cost, which here is only limited to the 3 months prior to enrolment in the study, so it's a very limited horizon. But we found again that patient-reported symptom severity is a significant determinant of NHS and societal costs. For every 1 point increase in patient-reported symptom severity score, and it's a score that goes from 1 to 5, okay, so 1 point increase, we see a relative 8% increase in NHS costs and an 18% increase in societal costs. And of those societal costs, lost productivity accounts for about 15%, which sounds very low, but might be due to the fact that the majority of our patients in this study were actually retired and not working. And I think because they were retired, they participated in the study. Working people were too busy, sadly. So patients who have very severe and very severe carpal tunnel syndrome have poorer hand function, experience high anxiety and depression, and have a lower quality of life, as well as incurring higher NHS and societal costs. Now, analytic studies like these have their limitations, and of course they cannot address the question of cause and effect. So we can't say that it is simply the carpal tunnel that's the cause of the psychological distress or the lower quality of life. And indeed, it's probably much more complex than that, where one contributes to the other. Now, we hope that the prognostic models that we're working on at the moment will give us an indication in the future of how we might be able to subgroup patients and offer a more stratified or personalised pathway for managing carpal tunnel syndrome. And also this could inform policy makers and commissioners how they spend their money and who is eligible for surgery. So perhaps we can only begin to appreciate how complicated our hands are when things go wrong with them. As for this cricketer, or indeed this lady who ran a milk bottling factory or business, and for the sake of one milk bottle that's worth 10p that she wanted to save, she stuck her hand in a machine. It only takes a split second for someone to make a wrong decision that can have life-changing consequences. Incidences of hand trauma presenting at accident and emergency often peak around the very sunny bank holiday weekends when chainsaws, lawnmowers and other DIY toys cause unimaginable harm. So, here's my public health message. Please be careful when you carve that pumpkin or when you let off that firework. Despite highly skilled hand surgeons and hand therapists, as well as all the advances and microsurgical techniques, we have not yet cracked the problem of how we restore hand sensibility. This is a picture of Zion Harvey, a young man in the US. He's the world's first child double hand transplant. He lost both hands from sepsis. Now, hand transplants are an operation that is controversial. It's not done very often, not least because these people spend a lifetime on immunosuppressant drugs to make sure the hands don't get rejected. And of course, they rely on a suitable donor. Now, his hands look almost normal. Yet, I think the lack of good sensibility is evident in the way in which this little boy transfixes with his eyes or fixes on the task to compensate for what his fingers don't really feel. Now, because he's quite a young lad, he's got scope to make quite a lot of improvement. Now, lost limbs are more commonly replaced by prosthetic hands, and it seems we are getting closer to emulating the complex discriminative sensibility of the hand in such a way that it actually is of functional value to the user. But there is still much room for improvement and room for innovation. So I want to finish by thanking all those giants of hand surgery and hand therapy on whose shoulders I have stood, and I hope I can see a little bit further. But all of this would not have been possible without the support from and the collaboration with many others. Research is done in teams. It has been and continues to be a real privilege to work with colleagues here at UEA, across the fields at Norfolk and Norwich, and further afield with people from across the world. I also feel immensely beholden to the National Institute for Health Research, the research arm of the NHS, because it's given me an amazing opportunity for career development and training as a researcher that I would not otherwise have had. But I also owe a personal debt of thanks to a few other people. Moya Wilson and Jenny Routledge, they were the founding directors of the School of OT and PT, Occupational Therapy and Physiotherapy, here at UEA when there was no health-related subject, even in the university. The medical school was not even somebody's twinkle in their eye. And they really inspired me with their vision to come and work at UEA. Also Richard Stevenson, who for many years was joint course director with me, later became head of school, and Fiona Poland, who came to us as our first director of research, for their encouragement in pursuing a research career. Also, I'd like to thank my two fellow angels, Jane Cross and Nicola Spalding. Jane isn't here this evening, Nicola is. Some of you may recognise this is a rather wonderful sculpture, Henry Moore's sculpture that sits on this beautiful campus that we obviously decided to deface. But I'd also like to thank my friends, my family, particular people who've come and travelled a very long way, and in particular my parents and my partner Lee. So to all of you, I thank you for coming, and I thank you very much for listening.
Well, good evening, everybody. I'm Rosalind Jowett. I'm Dean of the School of Health Sciences. And before I go any further, I just want to say thank you, Tina. What an engaging and informative lecture. Not just any lecture, an inaugural lecture. So thank you very much. It's this part of the evening where we do have some time for any questions or comments that anyone would like to make on Tina's session, or indeed anything perhaps, Tina. I wonder if there are any questions to start the session off. If not, I've got one. So a lot of what you had to say was new to me. Some was familiar, but there is one question which may be a bit of a silly one, really. Sensory relearning. Fascinating. I've not heard that term before. Would that have an impact on any other hand injury other than carpal tunnel? And if so, where would it have an effect?
Potentially. So sensory relearning can be applied to any disorder of the hand where you're trying to improve sensibility, functional sensibility. And of course, if you think about other causes of sensory disorders, so stroke, I think it has been used in stroke, and there are studies there. It is effective in stroke. The other, and I don't know to what extent it's been used, for example, in leprosy, because that's also a nerve disorder. I don't think there's very much research in that area. And another condition which it hasn't been tried, but it's something that I'm very much interested in, is a lot of people these days are cancer survivors post-chemotherapy and have chemotherapy-induced peripheral neuropathy. And they often have poor sensibility, but also quite a lot of unpleasant sensations in their hand. And
that wouldn't be easy to detect because they've got their hands physically, but they haven't got that sensory aspect. That comes.
So that's an area that is really rife for researching.
Right, very interesting. Anybody a question for Tina? Yes.
Yes. Could you tell us a little bit more about what's involved with sensory relearning? I mean, what do people actually do?
So one of the things that happens is that if you think about, if you hold a coin, let's say 50p coin, and if you close your hands and you manipulate it around, you can from touch alone work out its shape and the edges. Now, if you think about not getting all of those messages from your finger, only some of it, then when you go to pick up a coin from a table, you would use your eyesight to compensate for all the lack of information that's coming from your fingertips. And in sensory relearning, what you're doing is, to start with, you're actually taking away the crutch of vision. That's how I would describe it. And you force people to close their eyes and rely on touch alone. So it's very much feel and see what you can make of it. Now look at it, and of course the visual part of your brain tells you, okay, it's a 50p coin, and it can kind of help that. But slowly what you're doing is you're remodeling that representational area, and it takes a lot of intense practice. So you have to switch between looking and not looking, and then also then progressing to more complex shapes. So one of the problems with sensory learning is it is very repetitive potentially and can get very boring. And so one of the skills is to try and incorporate it into activities that really are interesting and meaningful for people. And I always remember in our large trial there was a gentleman who loved model building. He was retired, and he described sort of getting these packs of lots of little wooden shapes that he would have to pick up and put together in a puzzle, but build into a model. But they were often rough, and he would feel them and decide then whether he would have to smooth them a bit. And as soon as I showed him taught him the program, he suggested, well, maybe I can do this with my model, so my pieces. So he would actually pick them up with his eyes closed. He would see if he could feel the texture from feel alone without sight. So he forced himself to do that. And I think that was one of the reasons why he also derived much greater benefit, because he learnt a way of incorporating that. And you could almost say it's a form of mindfulness to your touch sense. So when you wash your hands and you feel the lather and the soap and you dry them, we're often not paying any attention to any of that, but it's almost being mindful of what you're doing. And therefore, the increased attention to that tactile input probably helps to strengthen those connections.
Does that answer it? Fiona?
I'd just like to pay what I hope is the biggest compliment I can to Tina. And this is because I'm a qualitative sociologist. I'm very concerned about how do people experience their topic, their research, how do they share this with people? And I just want to say that I don't think I've ever been to a quantitatively based clinical lecture which has brought us so many varieties of ways of sharing the experience of hand sensation through your choice of visual materials, through the stories, and through the kinds of issues that you've confronted us with. So I felt it was actually a very skilled, rounded, sensory experience that I will remember very much.
That was my intention, but thank you, Fiona. I appreciate that.
And that's some. Yes.
Thank you. Really, really enjoying an enjoyable presentation. It's great to see many of the next generation here, and I'm sure I know from your role in supporting and helping people's development that you'll be pleased about that as well, Tina. I wonder if you had any words for the kind of next generation of hand therapists. What do you think some of the sort of hot topics might be for those aspiring sort of new therapists?
Thank you, Anne. A difficult one. I think I'm going to, almost like a politician, evade your question about what the hot topics are, because I think the hot topic is whatever floats your boat, you know, what you feel really interested and passionate about. And for me, it was touch and sensation and reading the work of Eric Mobark. And, you know, I got myself into that world, and I've happily inhabited that. It may be something else for hand therapists that may be very topical of this time. But what I would say as a piece of advice is not so much what topics you should research, but follow your heart and go and seek help, knock on people's doors. Don't, you know, I think if I look back on my career, sometimes what's held me back is my own fears of finding a shut door, of appearing perhaps to be a fool if I ask that person. And when I've overcome that and, you know, perhaps gone and been brave, then, and I would very much urge them to do that. And I think as a profession, we often still hold back more so than others.
Very wise advice. Yes, at the back.
I lost the use of my hand temporarily through arthritis. I worked too hard, non-stop, for about 8 hours, and I found that I couldn't use my hands at all, and I rested and used mineral replacement, but it took 6 months to get my hands back. I used to play the violin. I had not played it at all for 20 or 30 years. I'm now taking it up again, but I'm being very cautious, because I don't want to lose the use of my hands because of it. Have you any comments?
Oh, well, I think there are other people in the audience that are probably better qualified to give special advice. I'm sorry that you lost the use of your hands. I mean, I think even just for 24 hours, I think that's a dreadful thing because we are so reliant on them. Again, what I would always say is what matter, to be able to do the activities that really matter to you, to try and find a way of doing that. I think sometimes it's very easy to say, well, if that makes your hand painful, then stop doing that. But actually, if that's really valuable to you, then that's not really good advice. So I think by all means, a little bit of everything, not overdoing it. You know, if you suddenly practiced 8 hours on the violin, we know that professional violinists get horrendous upper limb problems, serious problems. So I would simply say, look after them, don't abuse them, and continue trying to do and use them in a way that obviously is important to you.
Thank you.
So I think actually it'll be quite nice now that we can continue the conversation. We've got some refreshments outside, so please stay, and I'm sure we can stand in a queue to get some time with Tina as we have a glass of wine or something. I would just like to say I can't really sum it up better than Fiona did, except for me, I thought you combined really the art and the science of the hand and the beauty of the hand, and with the sadness of what happens when we lose it, and then ended with the hope, some of it with your research, on what can be done when you do lose it or it's injured. So I thought you combined quite a few emotions in your lecture. Once again, thank you very much, Tina. Thank you.